Okay, so let's move on a bit to cholelithiasis. So gallstones. So gallstones form in the gallbladder typically. And the gallbladder's main function is to store bile. So because over the years bile is stored and then released from the gallbladder and then stored again, you can form little cholesterol crystals that finally turn into gallstones. Okay, and the gallstones can be completely asymptomatic if they don't block a duct, such as the cystic duct, or they don't leave the gallbladder completely and travel down the common bile duct. Gallstones within the gallbladder do not cause any problems at all. It's only when they start to migrate and block ducts. Okay, so the presence of stones in the gallbladder can lead to obstruction of the cystic duct, and that would be called biliary colic or cholecystitis, and we'll get to those two conditions. If the stone is small enough, it can actually leave the gallbladder and get into the common bile duct, and that's called choledocholithiasis. And that can cause an assortment of problems. So if it gets stuck in the upper, like the common bile duct, well, now you've just blocked flow of bile from the liver, and that's going to cause all kinds of problems that we'll get to. If the stone travels down the common bile duct and then blocks the bile duct and the pancreatic duct, well, that's where you get blockage of bile from the liver, plus you get pancreatitis, because now you're blocking the pancreatic duct, and the enzymes that are trying to get out to help with digestion are now leaking from the pancreatic duct and auto-digesting the pancreas, and that's called gallstone pancreatitis. And we'll talk a bit about a few of these. Okay, so remember, gallstones, they're made from cholesterol typically. So what are the risk factors for gallstones? So definitely women, often over the age of 40. Not necessarily though. Multiple pregnancies. If you're on hormone replacement, birth control pills, obesity is a risk factor. Dieting back up and down with weights is a risk factor. High cholesterol and high fat diets. Definitely there's a family tendency. So often you might say, well, my sister had it, my mom had it, now I have it. So gallstone formation does run through families, but it's so common that it doesn't have to run through families. You can just get it anyways. And also prolonged TPN, total parental nutrition. So why is this the case for all these risk factors? So if you look at pregnancies, women, hormone replacement, obesity, dieting, it's all related often to estrogen. So women have more estrogen in their circulation, and estrogen is a risk factor for producing, or it can lead to production of gallstones. Okay, and that's why when you'll see it in pregnancies, women over 40, hormone replacement, obesity, because if within obesity you actually produce more estrogen, since you make estrogen from your fat cells. Dieting has to do more with fluctuations in cholesterol and fats, and that can also lead to gallstones. And so I remember it's it's typically a female. It's usually a female that's overweight as a risk factor, or one that's on hormone replacement. Now, that's not to say that men don't get gallstones. It's just these are much higher risk factors for gallstones. And remember, gallstones doesn't equal symptoms. Gallstones just means you have the potential to develop symptoms. If they sit quietly in your gallbladder and don't leave the gallbladder, and don't block any duct, then they're asymptomatic. Okay, so let's talk about cholelithiasis, which is the medical term for gallstones. So it's just gallstones in the gallbladder. So if you say I have cholelithiasis, then I would know that you're saying I have gallstones, but that's all. It's not saying that anything is blocked or giving you pain or anything. Okay, so the complications would be, let's say the gallstone travels to the cystic duct, which is the exit for the gallbladder to get into the common bile duct. So it's at the neck. It's at the neck of the gallbladder, and if it gets stuck there, you're going to get intense cramping and spasm of the gallbladder because the stone is blocking the secretion of bile. So the gallbladder is just going to contract intensely. So usually this is in the setting of eating fat or a fatty meal, and suddenly you get right upper quadrant pain. That's colicky. It's coming and going, and it's very uncomfortable. And you're often vomiting with it. You're nauseated. You're pale. And then most of the time, after we've given you some pain medication and some anti-inflammatories, it settles down. The stone goes back into the gallbladder and settles down. And we typically tell these people, don't have any further fatty meals. We're going to set you up for a formal ultrasound to look at your gallbladder. And if you have gallstones, you'll be considered for a surgical removal of your gallbladder, because that's the treatment. Okay, so that's biliary colic. So it comes, gives you miserable pain, nausea, vomiting, only to settle down again. So you don't typically have fevers or elevated white blood cell count because it's settled down by itself relatively quickly. And then it'll come again if you have another fatty meal. So we used to call these Big Mac attacks, right? So someone would go and have a meal at McDonald's. It would have some significant fat content, and then they'd have right upper quadrant pain, and it would be biliary colic. Now let's say that the stone doesn't leave the cystic duct, and the gallbladder becomes infected and inflamed. Well, that's called cholecystitis. So that's where you have right upper quadrant pain. So now you're a bit sicker, and you have fevers, an elevated white blood cell count. If you remember the diagram of where the gallbladder is, it lives on the underside of the liver. So an inflamed gallbladder can irritate the underside of the liver and cause some mild elevations of AST, ALT, bilirubin, okay, because it's irritating the underside of the liver. Okay, if we go a bit further, and the stone travels into the common bile duct, well, now you got a bigger problem, because now you have blockage of the common bile duct, and that is called choledocholithiasis, and that's where you get obstruction of bile flow. So you're gonna get right upper quadrant discomfort because the liver is blocked of bile flow. You're gonna get backup of bilirubin into the bloodstream, so you're gonna get jaundiced. You're going to get elevations of your liver enzymes, AST and ALT. And in particular, you're going to get elevation of alkaline phosphatase. Because alkaline phosphatase is made and secreted into the bloodstream when the bile ducts in particular are dilated. So you'll have elevation of alkaline phosphatase in the setting of a blocked bile duct. Okay. Um, so what else will you have? Well, you'll definitely have right upper quadrant pain. You'll have clay-colored stools. There's no bile getting to the digestive system, so there'll be clay-colored stools. If the stone travels further down and blocks the common bile duct and the pancreatic duct, now you're looking at all of those symptoms plus pancreatitis, and that's called gallstone pancreatitis. Okay, because it's blocking the digestive enzymes from the pancreas to get into the small intestine. So they're going to auto-digest the pancreas. Okay, so let's look at some tests. So an ultrasound, that's a great test to look at the gallbladder and the bile ducts. Anything that is filled with fluid, ultrasound is very good to look at. So gallbladder, well, it's filled with bile. Bile ducts, they're filled with bile, that's fluid, so we get fantastic views of it. Kidney is filled with urine. The bladder, filled with urine. So those are very good to look at with ultrasound. Okay. White blood cell count can help us with signs of infection. AST and ALT are hepatic enzymes that are released into the blood in the setting of hepatitis or hepatocyte injury. Alkaline phosphatase is released into the bloodstream in the setting of a blocked bile ducts. Serum albumin released with hepatic injury as well. Lipase and amylase, those are pancreatic tests. And lipase is even more accurate than amylase, but just for testing purposes, if you see lipase or amylase, that's for pancreatitis. Okay? The next one, an ERCP, endoscopic retrograde cholangiopancreatography. So this is just a fancy word for I'm going to put a scope down your throat, into your stomach, and then down into the duodenum, and then go into the little pore where the bile comes from, called the ampulla of Vater. And I'm going to put dye into the whole biliary system and the pancreas. And I'm going to look to see if there's something that's blocking the biliary system or the pancreatic duct. So that is a test to look at the biliary system or the biliary ducts and the pancreatic duct. Okay? So what kind of treatments can we offer people? So for someone who comes in with recurrent biliary colic, prior to having their gallbladder removed, and we know they have gallstones and they're trying to be careful by avoiding fatty meals, but they're still getting the occasional attack, well, we'll often use non-steroidal anti-inflammatories and sometimes narcotics to help them with their pain until it settles. We'll strongly recommend a low-fat diet to avoid the gallbladder from contracting and risking another stone to travel into the cystic duct. Okay, and then they follow up for a laparoscopic cholecystectomy, removal of the gallbladder, or an open, so a full incision opening to remove the gallbladder. So laparoscopic cholecystectomy versus an open cholecystectomy. It just depends on what the surgeon is able to do to get the gallbladder out safely. Okay, so we can probably go through this slide relatively quickly. Cholelithiasis, stones in the gallbladder. Biliary colic, stone in the cystic duct, which is causing right upper quadrant pain, very colicky, nausea, vomiting, and then typically settles down until the next time. It's aggravated by eating fatty foods, so we tell people don't eat fatty foods for now until you have your gallbladder removed. You don't typically get elevation of liver function tests or bilirubin since there's no blockage of the common bile duct. You can sometimes get very mild elevations just by the very, actually no, sorry, you can't get any elevation. I was on to the next topic already. The treatment is really just removal of the gallbladder once you're having these symptoms. Okay, cholecystitis, gallbladder, so gallstone that blocks the cystic duct, and then leads to inflammation and infection of the gallbladder. Same symptoms as biliary colic, except now you may be getting fevers and chills, elevated white blood cell count, sometimes elevated liver function tests and bilirubin, because the gallbladder is now inflamed and infected, and it may be irritating the underside of the liver, causing mild elevations of AST, ALT, and bilirubin. Okay, we often put these people on intravenous antibiotics to settle down gallbladder infection, the cholecystitis, and then they have a cholecystectomy to remove it. What can gallstones do? Well, so the next one, so biliary colic, we've done cholecystitis, we've done choledocholithiasis. That little stone has now left the gallbladder and traveled into the common bile duct. Bigger problem, because there's now backup of bile into the bloodstream. Okay, it's unable to get to the gastrointestinal tract, leading to clay-colored stools, so white stools. You're going to get elevation of AST and ALT and alkaline phosphatase in the bloodstream because there's no flow of bile. The liver is becoming irritated because it can't get rid of its bile. Your bilirubin is going to cause you to be jaundiced. Okay, and so choledocholithiasis is a gallstone stuck in the common bile duct. Gallstone pancreatitis is the gallstone has traveled a bit further down the common bile duct and is now blocking not only the common bile duct, but the pancreatic duct. Okay, and that's where you get into the combination of pancreatitis and lack of bile flow from the liver because it's now blocking the pancreas and the liver, this stone. Okay. So this is where typically you would need what's called an ERCP with the dye test, and it would show exactly where the stone is blocking the biliary system. And sometimes they can go in and retrieve it with an ERCP to remove the stone. Okay. Now you can only imagine that if you have a cancer of the pancreas that grows and blocks the common bile duct and the pancreatic duct before it drains into the duodenum, that's going to block the whole system as well. So if we see someone that comes in and says, I don't feel well, and they look very, very yellow, we often get very concerned that this might be a pancreatic head cancer. So head of the pancreas is where the common bile duct comes through, and painless jaundice. So you don't have any pain or anything, but you're yellow, you're jaundiced. That's very concerning for a cancer at the head of the pancreas. Okay, because typically if it's from a gallstone, it's usually painful as it travels from the gallbladder down the common bile duct. It's painful. So if you're telling me you don't have any pain, but you're really jaundiced, I'm concerned that you might have pancreatic cancer. So biliary dyskinesia, we're not going to spend a lot of time on this. I think it's something that happens once in a while. So it's an issue with the flow of bile into the duodenum due to an abnormal motility in the biliary system. So the bile ducts actually have muscles, and they can contract to move the bile down into the duodenum. So if you have abnormal motility or abnormal muscles in the biliary system, well, that's going to lead to right upper quadrant pain, right? And we're going to be very suspicious that it's gallstones causing this. So the symptoms are very similar. Right upper quadrant pain, nausea and vomiting, fatty food intolerance, because that's what gets the gallbladder contracting and the biliary system contracting. Painless jaundice. So why do you have painless jaundice? I mentioned that, by the way, in pancreatic cancer, which would be by far the most concerning cause of painless jaundice. But in this, just the whole biliary system isn't moving very well, so there's backup because there's no blockage, there's no stones. It's just the whole biliary system isn't contracting well, so bile is very slow to move into the duodenum. And you can get pancreatitis from it because the pancreatic duct is very dependent on the biliary duct. So if that's kind of not flowing well, then the pancreatic duct isn't going to flow well, and you'll get pancreatitis. So think of it as a lazy gallbladder, a lazy bile ducts, and a lazy pancreatic duct, all leading to a mimic of gallstones that are blocking ducts. But when we go to do tests, there are no gallstones.